very good evening, everyone. I am Vaishali Nath, Medical Advisor at Ajanta Pharma, and on behalf of Ajanta Pharma, I extend a very warm welcome to all of you to the Cardio Master Workshop Edition 5, a unique academic initiative specially curated for DM and DNB students. And it's a pleasure to see such participation across what we have seen in our last series as well. And it gives me an immense pleasure and privilege to have with us our distinguished course directors, Professor Dr. Ajay Mahajan, sir, intervention cardiologist and HOD associated with KEM Hospital, Mumbai. I again welcome you, sir, for today's event. We also have with us Dr. Dhiraj Kumar, sir, Assistant Professor, Department of Cardiology, KEM, Mumbai. Welcome, sir, again for today's DMPG program. Their continuous guidance and mentorship have been driving force behind this learning initiative. Thank you for giving us this valuable insights. We also have with us senior faculty joining today, Professor Dr. Aditya Kapoor, sir. I welcome, sir. He is associated with SGPGI, Lucknow. We also have with us Professor Dr. S. Tiwari, sir, associated with SGPGI, Lucknow. And we also have with us Professor Dr. Kamal Sharma, sir, associated with UN Mehta Institute of Cardiology Research Center, Ahmedabad, who is going to give us insight on a very interesting topic. So today we are going to have a case presentation on the topic of HOCM, which stands out to be again a very case and difficult, interesting cases happens in it. But before that, we will definitely have an expert lecture topic on dynamic auscultation, which is going to be taken by our expert, Dr. Kamal Sharma, sir. With this brief introduction, I would like to hand over the session to today's course director to set the context, and then we can proceed with the talks. Thank you.
So I'm going to take you through dynamic auscultation. I think this topic is important, of course, and a lot of things have been developing in this. I'm not going to cover what is just important in terms of what is dynamic auscultation when you're dealing with a case where this matters, that are the two important cases being mitral valve prolapse with an MR, or in a case of LVOT obstruction subvalvular or dynamic obstruction subvalvular, or even in that case to differentiate an LVOT obstruction, whether it's dynamic or not in nature. But that apart, there have been techniques that have been looked into now, and there are papers that are worked upon as to how you can corroborate the same in terms of echocardiography, cath hemodynamics, etc., when you're looking for a dynamic evaluation of a gradient. Definition-wise, of course, this includes, as has been classically described in Brunwald, as techniques as an assessment of altering circulatory hemodynamics by means of variety of physiological and or pharmacological. This can be a combination also. Maneuvers that determine effects of the heart sound and murmur. So whatever auscultation findings will change because of physiological or pharmacological maneuver is what is covered under this. Most often you would look into 6 important aspects: respiration, posture, isometric hand grip exercise or isometric exercises. Remember, this can also be modulated and told effect of exercise, because sometimes you may be asked about what happens if the patient undergoes not isometric but isotonic exercise. We need to understand the physiological aspects and hemodynamic impacts of the two exercises. That's how probably we can differentiate, and probably I'm not going to share that maybe in my presentation to keep something for on the lighter note, discussing it with our case presenters on the later half, so they know what one question I'm going to ask them. Valsalva maneuver. Again, sometimes you can be asked what happens if it's Muller's maneuver, which is just the reverse of Valsalva. Again, hemodynamics would differ. You would also be expected to know what are the phases of Valsalva, what are the hemodynamic impacts of each of them, and how the maneuver alters the sounds and the murmurs. Effect of premature beat, again, this can be clubbed with atrial fibrillation with long and short cycle. That's the other aspect of that. So each of the subgroups also has certain aspects. Same way in vasoactive agents, you may be asked mild nitrate versus sublingual nitrate or even nitroglycerin spray. Same way, the other way out of it would be phenylephrine and methoxamine, which have the alternating effects. Sometimes you may also be asked what would be effect of, say, vasoconstrictor agent like noradrenaline, adrenaline, or even say simple effects of adenosine, or even for that matter atropine, where the impacts on SVR, systemic vascular resistance, may not be so dynamic or just neutral, and the examiner may just trying to be confuse you around those questions. As you know, basically, this is the vigor cycle, as we know: isovolumic contraction, ejection, and relaxation, followed by rapid flow diastasis and atrial systole, the classical physiological Guyton chapter depicting this first physiological chart that we all crammed through in first MBBS in cardiovascular system examination. If you understand the impact of sounds and respiration from this chart, I think it's very much easy to reproduce and understand what would be the impact of various phases. So respiration, as you know, it's the negative intrathoracic pressure, which goes down with the negative with the inspiration. Remember, this can again be asked: what happens if the patient is on a positive pressure ventilation, say is intubated and is on a ventilator? What happens to effective heart sound? Because there the effect would be other way around. Inspiratory cycle would have positive pressure, and hence intrathoracic pressure would not decrease but increase, and the effect would be just the reverse. And hence the result, because of the inspiration of physiological inspiration, would be decrease in the intrathoracic pressure, which would result in more venous return to the right side. And because of the negative intrathoracic pressure, there will be decrease in the left flow. Also, some people say that the negative intrathoracic pressure of in the range of 2 to 4 millimeters of mercury would also be transmitted to the arch of the aorta, and hence the aortic pressure also tends to fall by 2 to 4 millimeters of mercury, apart from the decreased LV flow that may be impaired because of the negative intrathoracic pressure and blood pooling in the lung fields. The murmur that is generated in the right side will generally become louder, and the simple physiological extension of that is Carvalho's sign, where you have the posture and the inspiration both can augment the right-sided murmur of TS or TR. So in those with left hand side, on the contrary, the decreased flow would result in decreased intensity of those murmurs. So inspiration, normally there is dilatation of pulmonary vascular bed, increased venous return, Frank-Starling mechanism, increased stroke volume, which leads to also by reduced RVOT impedance, and hence respiratory variation also is accentuated in sitting and standing posture. So I usually ask the students who are not very profound with understanding of hemodynamics to remember simple dictum: all murmurs decrease except HOCM and MVP on standing and Valsalva. If you remember this line, if you can cram this line, everything is understood and covered in that one line as to what happens to various murmurs. So respiratory variation, usually standing, is when you would further accentuate because of the impact of the posture itself. So partial Valsalva phenomena is something that's also explained by what you call deep inspiration. So you don't have to ask patient to do a deep breathing in and deep breathing out. A normal inspiration is what you're looking for. It's not an augmented inspiration. Otherwise, you may have a partial Valsalva phenomena, and hence the effects may not be properly evaluated. So normal or slight normal breathing, you don't have to probably even instruct the patient, just observe what's happening with inspiration, expiration, and what is happening on standing and otherwise. Second heart sound respiration, it alters the splitting. We all know loudness in second heart sound in normal young adults in supine position. On inspiration, the S2 split increases, and that's why the best way to look for it is for them is this position. Expiration will split, will be narrowed, and S2 would become single. So when there is failure of S2 to fuse in expiration, which may occur in normal children and 15 to 20% of young adults, it may actually confuse you for a PAPDC associated ASD, but this may not be the case. Remember, this is normal splitting. With expiration, it's narrow. With inspiration, it becomes wide. And when you ask the patient to stand up, that's the best way to appreciate a splitting of second heart sound. So a standing respiration, normal respiration, would bring a best A to P2 during inspiration phase. Wide splitting, pathological the best way to remember electrical events, mechanical events. A too early, P too late. Divide it into these 4 groups and you don't have to cram what are the causes. So wide split, which means A2 is early electrical A2 would come if there is LV side pacing or if there is LF-sided DPB. Same way, if you have late P2, which is right-sided blockage, which is right bundle branch, that is electrical cause. If you look at mechanical cause, there'll be obstruction to the right side, so pulmonary hypertension because of the circulatory prolonged ejection and pulmonary vascular bed. And then the concept of hangout interval also comes in, where you look at the wide fixed split would come into play. Pulmonary stenosis would also delay P2. And again, left-sided pathway or pre-excitation, WPW syndrome, you will again get early A2. Wide fixed split, as you know, is a cause in secundum ASD. As you know, PAPVC may alter the fixed splitting and may be a exception to why you don't get fixed splitting in an ASD. Paradoxical split, the reverse of it. P2 is early, A2 is late. P2 is early because either right-sided pre-activation, which would be in a patient with our right, here it is not mentioned in the slide, is a pacemaker lead. So most of the pacemakers are right-sided. So even a patient who's got a permanent pacemaker, P2, A2 would be paradoxical. Left bundle branch block is again another cause, electrical activity of A2 being delayed, and A2 can be delayed when there is left ventricular outflow obstruction like aortic stenosis. S3 and S4, when you look at respiration, right-sided would increase. So tricuspid stenosis, OS or RVS3, RVS4 will increase. Expiration, the left-sided S3, S4 and opening snapomital stenosis would increase. Ejection click, only right-sided event that decreases on inspiration is pulmonary ejection click. Now, the physiological mechanism has very well elucidated in Abrams, even in textbooks like Joule's Constant and other books that you read. The inspiration will diminish its intensity simply because the valve now with inspiration, more RVEDP would make the valve move slightly up, and hence the amount of excursion or the rate of change of pressure with which the pulmonary valve now opens is lesser during inspiration, and hence this less upward movement of valve during systole would actually decrease the same. So this partial presystolic opening by inspiratory increase and rise in the position of the pulmonary valve, it makes the pulmonary ejection click as the only right-sided event, intensity of which decreases on inspiration. So all right-sided events increase except pulmonary ejection click on inspiration. This is the picture given in a lot of books. That's how it is with inspiration, expiration in diastole, and then from which position the valve is opening. If the valve is opening from this position, it will have wider excursion and it will be loud, but inspiration, it's already partially domed up, and hence it opens slowly, and this loud sound is no more loud as was expected otherwise. The murmurs, as I mentioned, left-sided versus right-sided, it's more consistent on right than left. Tricuspid murmurs, it's 100% sensitive, 88% specific. Inspiration increasing the right-sided venous return. Expiration as the same for the left side. So right-sided murmurs increase with inspiration. The murmurs that are accentuated during inspiration hence would include TSTR, PR, PS, especially mild to moderate, because severe PS will not, because it's already generating a gradient of something like 70 or 64 plus, and hence 3-4 millimeters of additional may not be appreciated by human ears, though even it may increase even otherwise in that scenario. Expiration or left-sided ones, MS, MR, AS, AR, BSD, and even pericardial rub is said to increase because of the lung tissue now not coming in between the stethoscope anymore and the rub, where it's best appreciated in the left anterior axillary line or across at the apex or just above the apex, where the rub now was more clearly audible because the lungs have collapsed. The mechanism is different, why the rub makes sense for the expiration to bring out the pericardial rub. Mitral valve prolapse, mid-ejection systolic click, and the systolic murmur, they would occur earlier during systole in inspiration. This is because of the reduced LV size, increased redundancy of MV, and increased prolapse. Same is the case with HOCM. Now that's where most important feature lies. HOCM MVP murmur mechanism. There's decrease in preload, decrease in LV and diastolic volume, more approximation of septum and MVL, which increase the LVOT obstruction and murmur intensity will increase. So there is increase in the afterload and increased back pressure during the systole over the LVOT will cause separation of the MVL from septum, decreasing the gradient and hence decrease in the murmur intensity. So we all know ultimately it's the LV size that matters. Anything that would reduce the LV size would make the murmur louder. Anything that increases the LV size would make the murmur because the approximation and the narrowing is now less, and hence the murmur would become reduced in intensity when the LV size increases. So HOCM murmur may decrease in loudness intensity with inspiration, and this is because of inspiratory increase in the gradient LV transmural pressure with resultant decrease in the LVOT obstruction. While in MVP, the decrease in the preload, there is decrease in the LV diastolic pressure, prolapse of the leaflet in the early phase of systole increases. So click and murmur is earlier. That the difference between HOC and MVP is for MR, that's the common question that's asked. How does an MVP MR versus HOCM MR change in dynamic auscultation? So click and the murmur become earlier and longer, while in HOCM it's louder. That's the difference between the two of them. So MVP, as this is how the structure is, and this is again a photograph given in a lot of textbooks, including our standard textbooks, where it mentions the sturged chordae, flattened leaflets, increase LV volume, and the regurgitation reducing, while ballooning and bellowing is increased with the decreased LV volume and more regurgitation takes place. In general, it's best to assess respiratory variation during normal respiration. Don't ask the patient to do, bring it out with extra effort. Effects of inspiration or auscultatory finding may be accentuated by Muller's maneuver, which is opposite of Valsalva. And as I told you, partial Valsalva actually blunts the effect, while inspiration you can actually accentuate them by doing a Muller's. But Muller's you should not mention as a part of respiration. It's a separate maneuver in itself. Forced inspiration against closed glottis, forcible inspiration while the nose is held closed and mouth is firmly sealed for about 10 seconds is the method to do it, the Muller's maneuver. In patients who have pulmonary hypertension and severe right RV failure may not demonstrate any augmentation, because here it's already working at the peak of the Frank-Starling curve. The ventricle is not going to accentuate or accommodate any more force for the increased preload or afterload that may be there. So it's already working at the peak of Frank-Starling curve. Reduction in preload or increase in the preload or reduction of the same, it's not going to unload or upload further the RV's ability to accommodate for the increase. So requesting these patients to stand and repeated cardiac auscultation, you may be able to appreciate the expected changes, but a lot of times these may not be there. Coming to second point is of postural change. Rapid standing, as you know, will decrease the venous return, the stroke volume, and this will cause a reflex increase in the cardiac rate and systemic vascular resistance. Also, width of the splitting becomes reduced. So there will be decrease in the intensity of RV events of RVS3, LVS3, and for after a couple of cardiac cycles, the blood goes to the left side. So even LVS3, S4 reduces in intensity. Decrease in the intensity of semivalvular stenosis, AV regurg, VSD, and some functional systolic murmur may also hence be appreciated. So since LV and diastolic volume is reduced, increase in murmur of HOCM, which has sensitivity of 95 and specificity of 84% respectively, even early mid-systolic click and the murmur of MVP may be noticed in this case. Squatting, this change from standing to squatting, there will be increased venous return because of augmentation of peripheral resistance due to kinking of the femoral artery. Both will happen together. So squatting abruptly increases the ventricular preload afterload and arterial pressure rises, and it can cause transient reflex bradycardia. This increase in stroke volume hence causes augmentation of S3, S4. Right-sided systolic murmurs like AS and diastolic murmur MS are augmented due to increase in cardiac output and the flow across the mitral valve. This elevation in the arterial pressure will also lead to further increase of regurgitation because systemic vascular resistance is there now elevated, hence AR would go up. In MR also will increase, so regurgitant volume fraction or the regurgitant fraction as we call will increase for both AR and MR. Even the left-sided shunts to the right in a patient of VSD would increase, and so would be the flow through RVOT in tetralogy, the mechanism of squatting in a patient of TOF. So combination of elevated arterial pressure, venous return, and increase in LV size and reduction in obstruction is something that's very pathognomonic in of diagnosing an HOCM murmur, and also the click murmur or MVP will be delayed. This again a photograph from Brunwald's textbook of cardiology, the old edition, which mentions the duration and impact of the LV size and the duration of murmur. And this is pretty much known to all of you. Now, posture, you may also be asked about left lateral, right lateral, sitting, leaning forward, etc. Right lateral for tricuspid, left lateral for S2, LV, S3, S4, opening snap, murmur, MSMR, and click of MVP in Austin Flint. Sitting and leaning forward, it's the ARPR and the mechanical sounds. Lying flat, passive leg raising will result in increase in venous return from sequential and increase in the right and the later on left end diastolic volume, stroke volume, and ejection velocities. This would lead to augmented valvular ASPS murmurs, TR, S3, and S4. It will reduce early diastolic of AR and HOCM murmur, and also MVP, and the click is delayed. Coming to isometric hand grip exercise, this is carried out usually by a hand grip device, what is also called as dynamometer. I mean, you can Google it and you can see image how it looks like. Some of them which are mechanical are pretty cheap, 100, 200 rupees. That's the amount. And you can actually look at the capacity of a patient to do an isometric hand grip exercise. This has also become important in patients with sarcopenia nowadays to look and quantify what is their exercising capacities. Also, it's better to carry out it bilaterally, performed in supine position, should be sustained 30-40 seconds. Valsalva during the hand grip should be avoided because this can lead to syncope. You can cause both of them together, and it can be very dangerous for these patients who are very sick. So don't do both of them together. So this is simple way, sustained hand grip. That's very common done, but you can use the dynamometer. As I mentioned, there are electronic dynamometers also available. Mechanical dynamometers are also available, and this can be done to look at what impact they can do. So what basically it does is increases cardiac output, heart rate, and pressure. It will increase the systemic vascular resistance and also LV and diastolic pressure. You can also ask the patient to do isometric hand grip using these kind of devices, but this also increases sympathetic drive, afterload, and filling pressure. So this would be contraindicated in a patient who's coming out of myocardial infarction, had recent myocardial arrhythmias or ventricular tachycardias or ventricular arrhythmias, who have got cerebral edema, severe hypertension, cerebral ischemia, recent stroke, recent pulmonary edema, patients of pulmonary embolism, borderline hemodynamics. Those patients you should avoid. And that's one of the common things that a lot of times examiners tell you when you are describing a case of MS who was hospitalized recently with class 4, decompensated, and you mention what happens to murmur of MS when you did isometric hand grip. They will ask you as to why did you do it, because that could have triggered a failure in a patient who was previously decompensated and has just been stabilized now. So hemodynamic effects increase cardiac contractility output without significant change in ventricular size. Isometric hand grip exercise hence increases cardiac output to some extent, provided the Frank-Starling curve allows it and it's not already working at a peak of it. Systolic murmur of AS will hence diminish because the grade SVR is now increased. Diastolic murmur of AR and systolic murmur of MR and VSD will increase because of rise in the SVR. LV-S3, S4 will increase and diastolic MS becomes louder as the flow across the mitral valve also goes up. Increase in the LV volume hence would reduce the systolic murmur of HOCM, MVPMR murmur also complex is delayed. So as I mentioned, you can do a calibrated dynamometer, or you can ask the patient to squeeze both the fingers of both the hands for 60 to 90 seconds. At least 30 seconds must be allowed to elapse before a significant change is observed. You should avoid concomitant Valsalva. Hand grip versus dynamic exercise, what's the difference? That's another thing that's very often asked. Dynamic exercise, you have increase in the heart rate and cardiac output to a huge and a greater extent compared to hand grip, while it's the blood pressure which rises more with the hand grip exercise, not so much with the dynamic exercise. So systemic vascular resistance changes only if strain is applied is more than 50% of the patient's maximum capacity, and that's why probably if it's known it would make more impact. Further increase in the pressure and augmented LVS3 seen in patients with LV dysfunction may be there apart from the heart rate, cardiac output, and SBP. And as I already mentioned, murmurs that are increased are AR, MR, MVP, and VSD. Murmur that are reduced would hence include AS and HOCM. The reason for variable response sometimes may be found in HOCM. This is very important because it's not very useful maneuver in HOCM. So though it may be of value for patients with MVP, this sustained hand grip is not something that's going to give you much value in HOCM because the SVR will increase, which will reduce the gradient, but tachycardia will increase the gradient. So these two will practically nullify each other, and hence the murmur may not change at all. So though you expect HOCM patients to have reduction in murmur compared to AS, that's how you differentiate. AS surely goes down, HOCM may or may not change. So that's the difference for dynamic auscultation for patients of AS with HOCM that may be asked to you. In rheumatic MS, tachycardia and complete LA emptying will increase the LA pressure and the gradient, and hence the murmur increases. Usually, as I mentioned, after a couple of cardiac cycles. To help to differentiate opening snap from S3 also and pericardial knock also, you can use this. Opening snap moves closer to A2, S3 does not change from position, and that's how you can differentiate the two. Coming to Valsalva, this is nothing but forced expiration against closed glottis. Standard way is to ask the patient to blow an anaeroid manometer, maintain a pressure of 40 for 30 seconds. Some books mention 20 seconds. But remember, sphygmomanometer, when it's mercury device, then there is a problem of mercury poisoning by accidental. The patient can have the spillage and he can actually end up consuming the same. And that's why it's not should not be done in mercury sphygmomanometers. It should be an anaeroid manometer. The other way is, of course, ask the patient to blow as if at a constipated stool. Other way is to ask the patient to raise the abdomen with mouth closed and breathing out with a forced expiration. Muller's is just the opposite. Close the nose with finger in mouth. Suck the finger with closed glottis or suck on a mouthpiece hooked to mercury manometer. Again, as I mentioned, it should can give rise to mercury poisoning. So sucking a mercury manometer is dangerous. Prefer non-mercury device. 10 seconds of 40 to 50 negative, but again, you cannot measure negative pressure, so it doesn't hold much of a value here. It increases heart, brings out, as we discussed, respiratory findings. All right-sided events will increase with inspiration, except pulmonary click we've already covered. The mechanism of this is already covered, except that I may cover different pathologies and variation. In pulmonary stenosis, idiopathic dilatation, click varies with respiration. But in pulmonary arterial hypertension, because it's already subjected to a PA pressure of the suprasystem or systemic levels, it does not change with your 3 or 4 millimeters of respiratory change. So it may not be appreciated, though it may move in the same direction. It's not appreciated very well. Second heart sound during respiration, we have already covered mechanisms. I'm going to skip this. A lot of times you may be asked why there is wide and why there is fixed split in ASD. Wide, 3 mechanisms. One, in ASD, patients usually have RBBB. So this RBBB leads to a lead aid P2. That's one mechanism. Second, the flow. The flow is increased from the left to right shunt. This leads to more blood going to the lung field, and hence the pulmonary valve is kept open for a longer duration. And A2 comes early slightly because the left-sided blood is reduced and is now shunting to the right. That second mechanism. Third mechanism is what is called as increased hangout interval. Hangout interval is nothing but the time of crossing over of the incisura between the PA and the RV pressure and occurrence of second heart sound. This duration is usually 40 milliseconds. In pulmonary, because of the increased pulmonary compliance in an ASD, which is a shunt present since birth, the increased compliance of the lung bed leads to increased hangout interval to an extent of 320 milliseconds. And these 3 mechanisms are the reasons why A2P2 become wide in an ASD. Why it's fixed? Fixed is because whatever respiratory changes do happen, it will be compensated by the shunt. So if you bring out 50 ml of extra blood by breathing into the right side, the shunt from left to right across the ASD, that 50 ml will not come and will be already adjusted for the respiratory pressure changes. So inspiration, therefore, does not cause a further fall in impedance, and does not further separate A2P2, and hence the A2P2 is fixed. Paradoxical, we have already discussed. Valsalva maneuver, coming back, methods I've already discussed, how to do that. Remember, if you do it prolonged, you can cause syncope, so just be very cautious that when the Valsalva has been done. So there are 4 phases as been described. Most of the findings that we discuss in a Valsalva are during phase 2 and 3. Remember, phase 1 and phase 4, pulse and BP have similar direction, and phase 2 and 3, the pressures again move in the same direction. Phase 1 is strain phase, blood squeezed from the lung into the left side, so there is transient rise in blood pressure, subsequent decrease in the right-sided cardiac output, and then there is a fall in blood pressure. Sympathetic stimulation with vasoconstriction and tachycardia hence sets in. While in phase 2, the release of the strain phase will lead to increase in the right-sided flow, followed by gradual increase in the left-sided flow. So right-sided murmur increase in the first 4 cardiac cycles, followed by 5 to 10 cycles when the left-sided murmur increase. Overshoot of sympathetic blood pressure due to previous sympathetic stimulation and vasoconstriction causes a reflex bradycardia. So phase 2 and 3, there is drop in the blood pulse rate compared to phase 1. So the abnormal phases, if they are absent, you should suspect what is called as a square root response. In certain conditions, you may have a square root response. The conditions that include are patients with incipient heart failure, patients with dysautonomia. It's also absent if the blood pressure during stay there is a ASD. So whatever overshoot is happening is compensated by an alternate flow or is a non-accommodative. In that case, the Valsalva may show a square root response. Also, one of the cause where you get square root response is mitral stenosis because of fixed cardiac output. So 4 conditions that I've already mentioned: dysautonomia, overt heart failure, ASD, and MS are 4 conditions where you get square root response in patients when you do a Valsalva maneuver. Transient decrease in coronary blood flow hence makes it contraindicated to do it in an acute coronary situation. All murmurs on the left side decrease in intensity, as I mentioned, except MVP and HOCM. This decreases LV volume, as we discussed, and hence increases the intensity and duration of murmur. Maneuver is unreliable. A dynamic obstruction increases and decrease in the LV volume. It's very specific, but not a sensitive sign for HOCM. MVP, apart, if you look at MS, an exception for Valsalva maneuver. Valsalva causes an overall decrease in the left-sided cardiac output, works toward decreasing the intensity of MS, ensuring tachycardia, incomplete emptying, blockage, backlogging of the elevated pressure, and the LV increasing. So above 2 mechanisms, they cancel out, and hence there is no change in the murmur of mitral stenosis. Differentiating A to P2 during strain, they are diminished in intensity. So during release phase, P2 first returns to baseline intensity, followed by an A2. So deep inspiration followed by forced expiration, closed glottis for 10 to 20 seconds is how we do. I've already mentioned how the maneuver can be done, the 3 techniques of it. So phase 1, as I've already mentioned, phase 2 already discussed. Phase 3 is called a relapse phase, where BP falls and there is temporary pooling of blood in pulmonary veins. And phase 4 is the overshoot phase, where overshoot of BP due to increased venous return and reflex tachycardia induces by the phase 3 hypotension. So phase 2, we've discussed all of them. The murmur of HOCM increased by 65% sensitivity and 95% specificity in this phase, and systolic click and MVP, they commence earlier. Phase 3, brief sudden decrease in blood pressure due to sudden decrease in intrathoracic pressure, while overshoot of systolic BP to increase venous return, reduce SVR, followed by reflex tachycardia is what you expect in phase 4. So this is the diagram, very again given in a lot of books, phases of Valsalva. And it should be performed in patient in supine, because you may have a patient pass out actually, and the upper part of the body is elevated no more than 30 degrees. Strain phase to be limited for 10 to 12 seconds only, should not be performed in acute coronary or CVA patients. Valsalva is helpful hence to differentiate right-sided murmurs from left-sided, of importance especially in identifying HOCM. During strain phase, there is attenuation of S3, S4, ASPS, MRTR, ARPR, TSMS. So practically all lesions, most of the sounds and murmur decrease in strain phase. Upon release, on the right side of the event, the 2 to 3 first 5 cycles, right side, 5 to 10 cycles, left side, the murmurs will increase. Now, second heart sound during strain phase of Valsalva widens markedly. On release, paradoxical splitting of second during strain, and then the accentuation in the long short cycles. There is augmentation, what is called post-systolic potentiation. This leads to onset of to increase intensity of murmur of outflow obstruction, increased contractility. But in HOCM, the increased contractility leads to further obstruction and more than the increase in the volume and the net increase in the gradient. So pan-systolic murmur of MR and VSD are not altered. Systolic murmur of papillary muscle dysfunction diminishes, and increase in LV size, delay systolic murmur, and a click of MVP. So this again, the Bernwald-Brocken phenomena, and it's cath tracing the gradient, how it goes up, and post-systolic potentiation in diastolic pauses in AFib. augmentation is AS, PS, HOCM, TR, AR, but the murmurs that don't change are VSD, MR, and tetralogy. So physiology pretty much is known. I've already discussed. AS hence have been covered in the same. MR actually is compensated by decrease in the afterload. The LA, the murmur of MR does not change. Also, the LA pressure, LA size does not change for the regurgitation. It will accommodate a fixed amount of blood, irrespective of what is the preload or afterload or force of contraction. TR does not follow the same principle of MR. This is because decrease in the afterload after a VPC is a feature of systemic circulation, not pulmonary circulation. The pulmonary circulation already is a low impedance circulation. As you know, the vascular resistance, the pulmonary vascular resistance, it's 1 to 2 Wood units. Peripheral vascular resistance is like 8 to 12 Wood units. So it's a high resistance circulation versus a low resistance circulation. The PR interval variation, it becomes abnormal atrial contribution to the ventricle decreases, and hence the stroke volume falls. So varying atrial contribution can cause a significant alteration. Soft S1 with long PR, loud with short PR is something that is known for it. Amyl nitrate, not easily available. You may not be asked to explain it theoretically, how it differs from nitrate. So the way is to crush an ampule in towel, take 3-4 breaths for 10 to 15 seconds. First 30 seconds, the systemic arterial pressure falls. 30 to 60 seconds, there is reflex tachycardia. And after a minute, there is positive inotropy and increase in the system, stroke volume, EF, cardiac output, heart rate, and ejection velocity. So this leads to a significant increase in venous return. S1 is augmented, A2 is diminished. Opening snap, my tricuspid valve becomes louder. A2OS shortens, RVS3, LVS3 are augmented, and LVS3 associated with MR decreases. This is one way you may be asked, how do you differentiate LVS3 of heart failure from an MR? Systolic murmur are accentuated for HOCM, AS, PS, TR, and also functional murmurs, and those that are increased with ventricular contractility and stroke volume. Due to fall in systemic vascular resistance, pansystolic murmur of MR and VSD will go down, and a diastolic murmur of AR will reduce. Austin Flint may disappear. That's how you differentiate it from MS. A continuous murmur of PD and continuous murmur of fistula also will diminish. You may just have systolic components, and diastolic may be shortened. Systolic ejection murmur of tetralogy diminishes because of the decrease in the arterial pressure and increased right to left shunt, and decreased flow in the RVOT tract. So amyl nitrate has these important features. It differentiates AS from MR, MR from TR, PS from tetralogy, PS from VSD, MS from Austin Flint, and PR from AR. That's the theoretical classical discussion around amyl nitrate. In HOCM, there are additional findings of augmentation of murmur due to decrease in the LV volume and systolic pressure with resultant increased gradient. It was earlier, this response has helped in differentiating HOCM from aortic stenosis. So AR murmur softens, MR murmur decreases. Methoxamine and phenylephrine. Methoxamine is no more easily used, but phenylephrine, of course, we all have. Increased systemic arterial pressure, reflex bradycardia, and hence it's contraindicated in hypertension patients. 3 to 5 milligrams of IV increases pressure by 20 to 40 with 2 to 3 minutes lasting for 30 to 40 minutes. Phenylephrine elevates it by 30 millimeters, again 3 to 5 minutes. Phenylephrine is preferred, as I mentioned, due to shorter duration. S1 is reduced, A2 is louder, A2O is prolonged, S3, S4 variable, and click occurs later and accentuate. Increase in the arterial pressure causes following murmurs to become louder. Early diastolic murmur of AR and Austin Flint, pansystolic MR, VSD, TOF, and continuous murmur of PD and AV fistula. Systolic murmur HOCM becomes softened. Click murmur MR of MVP delayed, and there is diminished ejection systolic AS and functional systolic murmur and MDM of MS. Transient arterial occlusion is another dynamic auscultation, which of the both brachial artery by peak of inflation to 20 millimeters above systolic will bring out a murmur of regurgitation like MR, AR, and VSD. So this is again a table from Brunwald again, looking for what is the effect of standing, supine, squatting, Valsalva, strain phase, release phase, isometric hand grip for HOCM and MVP. Remember, they all it's about duration in MVP and intensity in HOCM. That's the difference between them. And I've discussed the LV size as the primary driver of which murmur increases or not. So AS versus HOCM squatting and Valsalva can bring it out. AS versus MR hand grip, phenylephrine, VPC, and amyl nitrate can bring it out. So this is the murmur of differentiating AS from HOCM. So again, going by the basic dictums, most murmur, inspiration, expiration, right-sided increase, left-sided increase on expiration. Preload, most murmurs, increase preload will increase, decrease preload will decrease. Afterload, if it's increased, stenotic murmur decrease while regurgitant increase. Decrease afterload with amyl nitrate, systolic murmur, stenotic murmur except MS increase, regurgitant decrease. AS, HOCM, MVP, no effect of inspiration. Primarily, the nullifying effects we discussed for the same. Decrease murmur with preload, increase with afterload, decrease afterload will increase MVP and HOCM. Increase afterload will reduce both, decrease afterload will increase both. Congenital heart disease, VSDPS, murmur intensity decreases due to systemic vascular resistance rise through the systemic circulation and then the flow through the in tetralogy, decreased pulmonary blood flow due to increase in the right to left shunt. So differentiating PS of intake septum for tetralogy is again useful. PS murmur increases while the later decreases. Also, valvular MS from Austin Flint, I've already discussed. So that's it about what we can, I thought I will discuss. Probably the rest of the discussion we can leave for the case presentation. Thank you very much. If I can end the presentation and the screen share. Over to chairpersons. Thank you, Dr. Kapoor, Dr. Mahajan.
Excellent presentation. Too much learning for everybody, and it is a dynamic auscultation revisited. There are very, very minute points, and everything depends upon the hemodynamic changes because of some procedures. So thank you, Dr. Kamal. And without wasting any time, I will ask the team to start clinical presentation.
एक सेकंड सर, बस एक कमल एक क्वेश्चन है सर, एक उस पे कमल, डॉक्टर कमल.
यस सर.
सुपर प्रेजेंटेशन यार, मतलब आई माई सेल्फ लर्न सो मच. इसमें प्लीज एक्सप्लेन द मैकेनिज्म ऑफ पल्मोनरी इंजेक्शन क्लिक को, जो आपने डायग्राम भी बनाया था, एक बार फटाफट जल्दी से समझा दो बस.
राइट
अजय,
राइट. सो
2 मिनट
again, so when you breathe in, you bring more blood to the right side. When more blood comes to the right ventricle, RVEDP rises. So suppose RVEDP is 10, with breathing it now becomes 15. Your pulmonary valve will slightly tilt up. So instead of going from this stenosis to opening like this, now it's already up halfway, and now with inspiration it kills like this. So this excursion is lesser compared to this excursion, and this movement will give louder click compared to this click. And this is because it's already tilted. More blood has come in with inspiration. RVDP, this is the lower part is RV, more blood inside, tilts slightly up, and that's why it's diminished on inspiration. So only right side element
more cephalic position of the wall leaflet, because of that less movement and less sound.
Correct, sir.
I think very nicely explained the dynamic auscultation, Dr. Sharma. And I'm sure most of the residents have benefited, because clinical differentiating aortic stenosis from HOCM and then further differentiating from the supravalvular AS is very important. And with this maneuvers, dynamic maneuvers, one can assess the, make the correct approach in severe aortic stenosis or LVOT obstruction. Very well, very well done.
Thank you, sir.
Good evening, respected teachers. I'm starting with the case presentation for the evening. This was a 30-year-old male resident of Lucknow, UP, a shopkeeper by occupation, who presented to us with the chief complaint of exertional breathlessness for the last 5 years, exertional chest pain for the last 3 years, and a history of episodic palpitation followed by syncope 6 months back. Coming to the history of presenting illness, patient was relatively asymptomatic 5 years back when he developed breathlessness on exertion, which was initially on walking up to his shop, which was around 1.5 kilometers away from his home, or climbing up to 2 flights of stairs, which is suggestive of NYHA class 2, and has gradually progressed to breathlessness on doing household activities like dressing, undressing, taking bath, and climbing 1 flight of stairs, suggestive of NYHA class 3, over the course of last 1 year. This breathlessness was relieved by taking rest and was not associated with fever, cough, expectoration, any diurnal or seasonal variation. There is no history suggestive of orthopnea or PND. Patient also gives history of chest pain on exertion for 3 years, which was retrosternary location, constricting in nature, not radiating to any site, relieved by taking rest, initially on walking up to his shop around 1.5 kilometers from home or climbing 2 flights of stairs, and has gradually progressed over the last 6 months to chest pain on doing household activities, suggestive of NYHA class 3. Patient also has history of 1 episode of transient
What
loss
is
of
class 0, Anshuman? What is class 0?
class. NYHA class is, sir, 0. NYHA 1
What is
is
NYHA class 0? You know class 1, class 2, class 3, class 4. I'm asking what is class 0. Are you aware?
in a person in whom the cardiac illness is not yet known or not recognized yet.
So
And is
in the first
asymptomatic.
NYHA, when was NYHA published? So in the first paper, they mentioned NYHA when they were not looking at the data sets. If they could not know, they did not know, they mentioned it as 0. So 0 does not mean supernormal. It just means that it's not stratified.
And asymptomatic.
Okay.
Yes.
Okay. So compared to the original NYHA, what were the other indications that were excluded later on, or what are the changes that have happened from the original NYHA to the current form that we know? If you are aware? So if the examiner wants to grill you on NYHA, so you can sometimes go on these kind of questions. So just to know whether you have read that paper, the first consensus paper that was published. It doesn't make to the clinical sense to why it should matter, but more sense it makes that if you are aware of bendopnea, etc. But I'm sure bendopnea has been discussed by Dr. Kapoor and Dr. Mahajan a lot of times. So I'm asking you something different.
Yes, sir, I'm not aware of.
Okay, so they had included abdominal pain, hemoptysis, just like in rheumato, the original Jones. Some of those things were still peeped in, and then they all were removed. They just wanted cardiology to be around. So all those things were excluded. Also, there was what they had initially stratified as 2A and 2B, and then this again was discarded. So I remember my teachers writing NYHA 2A, 2B, and then this was discarded, no more use. And that's the other thing that happened. And the third thing was class 0. Those were the 3 things. Any other classification that's easy to do? Or let me ask you the other way around. Where is NYHA not used in cardiology?
Sir, in syncope.
Which are the cardiovascular disorders? Sorry?
Sir, it doesn't include the syncope as a symptom, sir. It includes...
No. I'm saying patient has dyspnea. Patient has got dyspnea. Patient is a cardiac patient. And still you don't use NYHA classification as a classification. You use some other classification instead. Tell me the disorders where it is done like that, where you would not use NYHA. And if you can tell me why it is so, I'll be more than happy as well. Why it is not used.
Sir, in pulmonary arterial hypertension, we...
Very good. Very good. We use which classification?
World Health Organization.
Yeah, correct. WHO. Why you don't use NYHA there? What's wrong? You can use that as well, no? Why you want to use WHO?
You had actually answered a few seconds before you mentioned PAH. So
it doesn't include syncope as a symptom.
Correct. 1 second.
And 6 minutes. And in PH, we see for walk test.
No, the walk test is a measure of prognosis. It's not symptomatology, right?
Yes.
So, what was the survival difference? How were these do-they patients used to present? When did the WHO do it? What about children? Can you use NYHA for children?
No, sir.
So, what classification is used there? So, if you know, I mean, I'll ask you a question other way around, you'll remember. It's just the examiner's trick of, asking you a question in a twisted format. That's all.
Sir,
What classification
other
you use? Now you answer me. You'll tell me all classifications.
other classifications include, sir, Perloff and Minnesota, sir.
Modified
UCLA
Moss,
and
Perloff,
Perloff.
modified Moss,
Yes,
Perloff. Correct. So that's where you don't use NYHA, right?
yes, yes.
Any
One
other
more disease
classification?
where you don't
Yes,
use
sorry, go ahead.
NYHA classification. Some people go ahead and do fellowship in that. Peripheral arterial disease.
Arrhythmia, sir, is peripheral artery.
Peripheral arterial disease. So you have Rutherford and Fontaine classification there.
Rutherford and Fontaine, yes. Yes.
Any other classification that you know which can be used in cardiology where you can also use NYHA, say for dyspnea, say for angina? So what classification do we clinically use for angina more so, NYHA or some other classification? And why so?
Sir, we can use Canadian classification system or
Why do we
Goldman.
use CCS more often than... So angina is primarily, a lot of times people write, it's fine. I mean, either is fine. It's okay not to use one. But some people prefer CCS over Canadian Cardiac Society over NYHA. Why?
Because Canadian is more objective as compared to NYHA. It is more subjective.
Very good. Very good. So that's it goes on to tell you why. So there is a comment, palpitation is not a feature of PH. Hence, it's... No, that's not the reason. That's not just one reason why it's not. It's not. See, remember, four symptoms can be assessed by NYHA. Does not mean that you cannot use NYHA for something else. Or I mean, sorry, the other way around. I mean is because you want to assess dyspnea.
Yes.
And patient does not have palpitation, so don't use NYHA. That's the wrong logic. That's what I mean to say. ऐसा नहीं है चारों होगा तो ही मैं NYHA use करूंगा. चारों में से किसी के लिए भी use करूंगा. You can use NYHA for any four of them. That's what it means. It does not mean that if you don't have palpitation, you cannot use NYHA for dyspnea. Not like that.
Yes.
Okay.
I have a question for you. When you have described
actually,
chest
Aditya,
pain
for one patient,
yes, sir.
I mean, practically it is not possible to, the same patient you have NYHA, at the same patient you have Canadian.
Yes.
Irrespective of if there are multiple symptoms. So practically speaking, to convey to the other person is one classification to make it more practical to understand.
Yes, sir.
Yes.
Would you include post-meal angina also in this description of chest pain? We have said that it has progressed to NYHA class 3, the angina. So
why is it important?
Yes.
Dr. Dhiraj is asking a very important question. Why is it important, this postprandial and for a patient with angina?
Post-meal angina, sir, it is in coronary artery disease where the blood flow is directed for...
That's a different thing. Not all patients of CAD present with you a postprandial angina only.
The blood flow in splanchnic is increased as compared to coronaries. So
how is it related to your case of HCM? Is it more common or less common? Postprandial angina in a patient with HCM?
It is less common.
Sure. Now apply the principles of dynamic auscultation. What happens when you eat? Where will the blood go? Will the intestine ask for more blood or less blood when you eat?
More.
When you eat irritants, what does it cause? Flushing on your face. What do you expect to the gut? When
Gut
you eat a lot of
congestion.
mirchi vada, what happens to your intestine, to your splenic circulation?
Increased blood flows.
So there is what? Systemic vascular resistance. There is fall or rise. There is vasodilatation, na? In the sphincter.
Vasodilatation.
So what?
Fall in
Vasodilatation. What happens
fall,
to SVR?
fall in
So
SVR.
SVR has
Yes.
fallen. What do you expect for the LVOT gradient to go now?
Increase. LVOT
Increase. What
gradient
do you
will be
expect for
increased.
ischemia and angina?
It will be more pronounced, sir.
So you know it, right? Just you need to
Yes.
apply when you're asked the question.
Yes.
So angina actually is brought out in a
Similar
patient.
A similar
Yes.
parallel is alcohol consumption. That also
Yes.
brings out
Yes.
angina in patients with HCM because of
Yes.
fall in SVR.
Yes, sir. Okay.
Chalo, aage chalo, nahi to I'll just keep asking you on your HOPE.
Patient also has a history of one episode of transient loss of consciousness around 6 months back, which was abrupt in onset and associated with abnormal awareness of heartbeat for few seconds preceding the episode. And it was followed by spontaneous recovery without any residual focal neurological deficit, which is suggestive of a syncopal attack. There was no associated visual or auditory disturbances, jerky limb movement during episode, involuntary urination or defecation, tongue bite, prolonged confusion after episodes, or any right or left sided limb weakness. There is no history or suggestive of edema of feet, abdominal pain, decreased appetite, nausea, or vomiting. There is no history of hemoptysis. There is no history of hoarseness of voice or difficulty of swallowing. And there is no history suggestive of prolonged fever or skin lesions. Coming to the past history, there is no history of migratory joint pain in childhood. There is no history of major medical or surgical illness in the past. Personal history was uncontributory.
So you're sure this syncope was cardiac?
Sir,
how did you know this is not a neurologic syncope?
Sir, because it is more in favor of cardiac because there was it was not associated.
As a history, can you differentiate whether it's a cardiac or non-cardiac syncope?
Yes, sir.
What is that methodology?
Sir, neurological may be associated with preceding
Any scoring
aura.
system are you aware? EGASIS criteria, have you heard of?
EGASIS. Sir,
I would have asked you क्या percentage होता है, क्या sensitivity होती है, क्या specificity होती है, cardiac versus non-cardiac differentiate करने की, कौन से criteria होते हैं. So you should know how do you differentiate. Suppose duration क्या है, post-ictal confusion है,
yes.
Duration more than 20 minutes है, seconds है, post bladder bowel involvement है, tonic movements है, tongue bite है. Yes. Those are some of the things, but those are not EGASIS criteria. EGASIS criteria, some of them are EGASIS, some of them are the additional features. Go through them. If you'll search, you'll find them. And then there is a scoring methodology. It's given in a lot of books. You score it and you know it's cardiac or non-cardiac.
Okay.
Right? So may I add something to that?
Yes,
whenever you're talking about syncope and you have already made up your mind that there were palpitations and after that the patient had syncope, that does not mean that there are no mechanical causes of syncope. So you must mention whether exertional or post-exertional syncope was present along with these episodes or not.
Yes.
And that would actually shed light into what is the mechanism of syncope and what is the pathology that you are dealing with.
Yes, sir. So there was only one episode of syncope and it was preceded by an episode of abnormal awareness of heartbeat for few minutes and it was non-exertional, sir.
So he doesn't have exertional and post-exertional syncope?
No, sir. He doesn't give history suggestive of syncope.
But just for your understanding, what kind of syncope do you get in aortic stenosis versus HOCM?
Sir, in aortic stenosis, it's more of exertional syncope, and in HOCM, we may get exertional and non-exertional both due to arrhythmias, sir.
No, so forgive me if I'm wrong. I think exertional syncope is aortic stenosis, post-exertional syncope is HOCM, and that is the way to distinguish. Can you tell me the pathophysiology of both? Because this is again a commonly asked question. Why does syncope occur in HOCM and why does syncope occur, mechanical cause of syncope in AS and HOCM?
Sir, in aortic stenosis, it is due to fixed cardiac output state. So with exertion, the cardiac output remains fixed, and the increased demand of the cerebral perfusion is not met. So there occurs syncope
No,
in
so
aortic.
if you are attempting a DM level examination, you have to say that along with a fixed orifice, there is also an inappropriate systemic vascular resistance fall due to LV mechanoreceptors, which causes a diminution of blood flow to the cerebral circulation as a result
Yes.
because of steel to the lower body. And that is one of the mechanisms in aortic stenosis. Actually, there are three. What is the mechanism that explains post-exertional syncope in HOCM?
So post-exertional, there is a decrease in the systemic vascular resistance
Okay.
in
And
HOCM. So due to the basal gyrus reflex, sir,
you have to invoke the role of catecholinergic release
sir,
post-exercise, which
post-exercise,
leads
yes.
to increased LVOT because of vigorous contraction, and that leads to syncope. Obviously,
So,
SVR may rise or may not rise, as Kamal sir said very interestingly. Isometric and isotonic exercises, isotonic are two different things altogether. So you must be
due to,
very clear with the hemodynamics whenever you are presenting a case.
due to the increased sympathetic activity, sir, there is a increased heart rate contraction. And with increased heart rate contraction, there occurs increase in the gradient, LVOT gradient, which may result in.
Can you explain the? Go ahead, please.
Have you finished the history part, Aditya?
No, sir.
Ajay, just go ahead with the history.
In family history, his father died at the age of 48 years with no past history of cardiac illness, and he has one elder brother who is suffering from similar complaints. Coming to summary, a 30-year-old male presented with gradual onset dyspnea on exertion for 5 years and angina on exertion for 3 years, initially in NYHA class 2, which has now progressed to NYHA class 3 for the last 1 year, with history of 1 episode of syncope and family history of sudden cardiac death in father.
So you presume this to be autosomal dominant,
Yes, sir.
whatever condition we are dealing with. What are the common autosomal dominant conditions that afflict that patients can get afflicted in cardiology? Do you know of some?
Sir, HOCM is the one.
Okay. What else?
Sir, in others are channelopathies, some like long QT syndromes, sir.
Are they mostly autosomal dominant? I agree, there are few, but most of them are autosomal recessive.
And sir, in Marfan syndrome, sir.
That is autosomal dominant?
Yes, sir.
Good. And there is incomplete penetrance. So HOCM is autosomal dominance with incomplete penetrance.
Yes,
So
sir.
that is something which gives away the diagnosis.
Yes, sir. So on history, my differential diagnosis will be first will be cardiomyopathy of hypertrophic obstructive cardiomyopathy. Others will be multivalvular rheumatic chronic rheumatic heart disease with mitral and aortic stenosis. And lower down will put bicuspid aortic valve aortic stenosis and young onset premature coronary artery disease, aortoarteritis, pulmonary artery hypertension, and remotely MVP.
Can AS with MS have a 5-year history, symptomatic history?
Sir, MS, yes, sir. The patient is currently at 30 years of age and he presented with symptoms from since he was 25 years of age. So mitral stenosis can have a long and variable course, sir. And the LVOT obstruction symptoms which are occurring may be because of associated aortic stenosis lesion.
Because you don't have exertional syncope and you don't have orthopnea PND. I think you mentioned specifically that there was no orthopnea and PND. That's
Yes.
why I'm asking that the hallmark of both these diseases are absent. So logically, it looks less likely. Anything can be possible in cardiology and medicine, but logically less.
Yes. Coming to the examination part, in general examination, patient was conscious, cooperative, and oriented to time, place, and person. He has a BMI of 21.45, with arm span of 165 and upper segment of 92 and lower segment of 82, which is normal. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Back and spine examination was normal, and there was no dysmorphic facies or marfanoid features. Blood pressure was 112/68 in right upper limb, 114/66 in left upper limb, 118/68 in both the lower limbs. Pulse was 84 per minute, regular, normal in volume. Carotid was bifid in character, no radial or radiofemoral delay. The arterial wall was normal in condition and all peripheral pulses were palpable. The respiratory rate was 16 per minute, abdominothoracic in character, and temperature was 97 degrees Fahrenheit. JVP was not raised with a height of 3 centimeter above sternal angle at 45 degrees in head up position. There were normal A and V waves with normal descent. A was more than V. Abdominal reflux was negative with normal respiratory variation. Coming to cardiovascular system examination. In inspection, the chest was bilateral symmetrical. Transverse diameter was more than AP diameter. Apical impulse was visible in left fifth intercostal space, just medial to the mid-clavicular line. There were no other impulse visible in precordium, parasternally, supraclavicular, epigastric, or interscapular region. And there was no scar, sinus, fistula, or dilated veins. In palpation, the apex beat was palpable in left fifth intercostal space, 2.5 centimeter medial to mid-clavicular line. It was heaving type with medial retraction. Double apical impulse was palpable both in the systole and a presystolic palpable S4 was present. There was no palpable S2, S3 or pericardial knock. There was no thrill or parasternal heave. In percussion, the liver dullness was present in right fifth intercostal space in mid-clavicular line. Left heart border was corresponding to apex and right heart border was substernal. The left second intercostal space was resonant. Coming to the auscultation, S1 was normal, S2 was normal in intensity with reverse split. LV-S4 was best heard at apex in left lateral decubitus position with bell of stethoscope and a harsh ejection systolic murmur of grade 3/6, which was long in duration and peaking in late systole. Best heard at left third intercostal space with diaphragm of stethoscope, crescendo decrescendo in shape, non-radiating to carotids, better heard in standing and Valsalva maneuver, and decreased intensity with supine and isometric hand grip. So my provisional diagnosis was severe left ventricular outflow obstruction at subvalvular level in form of HOCM with no PH in diastolic heart failure in NVHA class 3 in sinus rhythm with family history of sudden cardiac death.
Can you defend each and every word of this diagnosis? Why do you call it severe left ventricular outflow tract obstruction?
Yes, sir. Severe because in examination we are getting palpable S4 with a harsh long duration ejection systolic murmur and a reverse split S2, which are all features of severe left ventricular outflow obstruction.
Again, you fall into the trap. Whenever an examiner asks you, I would like to ask Dr. Aditya Kapoor sir's opinion also. Why severe? You should start always from history. You have class 3 angina
Yes, sir.
and class 3 dyspnea on exertion. Obviously,
Yes.
these two would support a severity of the lesion. Of
And
course,
there was a history of
HBOTO is not
syncope.
may or may not be severe because you don't have exertional syncope, post-exertional
Yes.
syncope. Okay,
Yes, sir.
that is one
I mean,
thing.
I usually tell my students, you should say start from name whenever you are asked. Does this
Yes,
name
sir.
warrant that you have severe aortic stenosis? No. Does his age warrant that he's severe aortic stenosis? Does
Yes,
his gender warrant its aortic stenosis?
yes,
So start that way, right? From the way you
yes.
start your
So,
history. So then you'll not forget.
Yes, sir.
so you should always rephrase it as severe dynamic left ventricular outflow tract obstruction at
Yes, sir.
subvalvular level
Yes.
in the form of HOCM with pulmonary. You should mention about hints about pulmonary venous hypertension, which is obviously there in this case, as you said
Yes.
that there is a dyspnea, and
Yes, sir.
of course you have talked about pulmonary arterial hypertension, but some degree of pulmonary arterial hypertension is expected when such a severe HOCM is there because there's going to be diastolic dysfunction.
Yes.
Um,
Yes.
in congestive heart failure or diastolic heart failure, again, I don't know how to defend this. I would ask my senior examiners to talk on that. And you have to always write high risk for SCD subset in the final diagnosis of HOCM because two of the factors that are very important, obviously, are family history and this patient has an unexplained question of arrhythmic syncope. So
Yes,
these
sir.
two things are very high in the order of sudden cardiac death. So if you can include that, then obviously there will be some weightage given.
Yes, sir.
Uh, 12 lead ECG with the normal standardization and calibration with the heart rate of 60 beats per minute in normal sinus rhythm with mean frontal QRS axis 0 degree and left ventricular hypertrophy as per voltage criteria with a strain pattern with no evidence of LA enlargement and bundle branch block. Now coming to chest X-ray. Chest X-ray PA view, which shows slightly rotated slightly right anterior with adequate exposure with CT ratio 50% and LV apex with no obvious chamber enlargement. Pulmonary artery segment appears to be normal. Aorta appears to be normal. No evidence of PBH.
What is the differential diagnosis of the ECG that you show?
Sir, HOCM, first one is hypertrophic
No,
obstructive.
Why not?
but
Why not something else? What are the differentials?
Valvular, yes.
Valvular aortic stenosis.
Why not
Hypertension.
valvular stenosis? What are the conditions? I mean, there is a beautiful picture in Grunwald where three important differentials are mentioned for at least 16 versions, and they've differentiated how they differ.
Valvular aortic stenosis, HOCM, and coronary artery disease, sir. In coronary
Coronary
artery
artery
disease,
disease and CVA.
CVA, yes, sir.
So how do those differ?
Sir, by the symmetry of the T-wave inversions, we can differentiate them, sir. In CVA, we get symmetrical deep T-wave inversions, and in CAD, we can have a dynamic change in T-wave. Or in HOCM,
How will you see from this ECG?
in HOCM, we will have a asymmetric T inversions, sir.
So, asymmetric.
And in coronary artery disease,
Slope and upslope, down slope and up slope.
yes,
That's what you need to look. Down slope and up slope.
yes,
Symmetric, biphasic. Biphasic, where do you get biphasic?
biphasic we can get in coronary artery disease and HOCM.
HOCM, do you get biphasic?
No.
Okay, which leads are not involved or not showing T inversion in all these conditions? Which condition will have associated
Lead
delta?
AVR will not show.
What do you think about PR interval in this patient?
PR interval is normal.
Normal.
Actually, it is less. And what sir is
Normally,
trying to
Yes,
drive
sir.
home the
Yes.
point is many times
Yes.
WPW
Hmm.
also can have pseudo LVH like signs
Correct.
and
So,
be
right. So it's here if you look at PR, it's borderline
Borderline.
120
yes.
to 122.
And
Right?
and some familial versions of HOCM also have associated pathways.
Associated the pathways. So accessory pathway may be present in
Yes.
patients with HOCM.
और जो डॉक्टर कमल पूछ रहे थे ना तुमसे asymmetry versus there is some older books also used to mention this. Look at this T wave overshoot.
Yes.
Yes. Yes, sir.
Yes.
Based Luna, I think, had a paper on this T wave overshoot in LVOT obstruction. Sir, I wanted to ask you a couple of things. Often, when people are presenting HOCM, when they talk about angina, should they talk about variable threshold angina? Because HOCM obviously essentially is a variable LVOT disease. That is one thing. Second thing is he mentioned the pulse as bifid and normal in character contour, but shouldn't you get a rapid brisk
Because
rising pulse? Because you're clearly going hinting towards an obstructive variant of HOCM. I'm a little not convinced with the kind of pulse that you described, and I think that you should have talked about variable threshold angina in this case.
Aditya,
yes,
Anshuman, what is the pulse you have described?
sir, the pulse
Can you go
was,
back?
sir. Yes, sir.
So do you think the bisvariance of HOCM, how does it differ from ASAR?
Sir, the pulse in this patient was with a rapid upstroke associated with the mid-systolic fall and followed by
Yeah,
a
because you have not mentioned
late
rapid
systolic.
upstroke. I was looking at rapid
Yes, sir.
upstroke there.
It
And one of
was.
the
It
classic
was.
thing is when you are thinking of LVOT and you
Yes,
get a
sir.
rapid upstroke, you straight away knock out
Must.
aortic
Yes, sir.
stenosis and you think
Yes, sir.
about
Yes.
this thing. And what sir is asking is a very important question. Difference between the bisvariance of HOCM versus ASAR. Can you tell me that?
Yes, sir. In
What is it?
bisvariance of ASAR, sir, both the peaks occur in the systole and both are of same amplitude. But in HOCM, the first peak is with rapid upstroke is of a larger amplitude as compared to the second peak, although it also occurs in systole.
So that's called a spike and dome pattern.
Spike
Spike
and
and
dome
dome
pattern
pattern.
or finger
Yes,
Correct.
sir.
pointing
And
pulse.
more
Finger point.
importantly, is it
Yes.
more palpable or more recordable?
Mm.
More recordable.
Correct. So spike and dome is more recordable than
Yes,
palpable.
sir.
Usually,
Because
vegetarians
yes,
think of ASAR, unless, of
yes,
Yes.
course, you can get a bifid where the two peaks are not equal, as you mentioned. That's how you
yes,
Yes.
differentiate the two. And also, HOCM, as sir was saying, variable angina is one thing. There are certain symptomatology questions, so like postprandial angina. Then there is no occurrence of PND. That's another feature.
yes.
Why do
The
the
Yes, sir.
patients don't get
Adit,
PND in HOCM? They don't get. Why?
Adit,
Yes, sir.
the most important point in pulse is the upstroke, whether it is a
Yes,
Yes,
sir.
rapid or a slow.
rapid. Yes,
You
Yes,
yes,
sir.
forget everything.
Yes,
yes.
sir.
It is the
The D.
upstroke which decide whether it is a valvular or
Aortic
something
stenosis.
else.
Yes. Yes, sir. Yes. Yes, sir.
Yes. May I ask you something? Why is there a spike and dome in the pulse?
Sir, because the initial rapid upstroke is because of the ejection of blood in the early part of systole,
Which
and
is
with
relatively unobstructed.
yes, sir. And
Correct.
when the ejection of blood occurs, there is reduction in the LV volume, and the gradient increases. So the second the after the mid systolic fall, the second rise is relatively less because the
No, no,
gradient
there
has
is a
increased.
dip. The dip is due to progressive LVOT obstruction, due to
Yes,
Venturi effect, pulling the
eventually.
systolic the anteromitral leaflet and
Drag
causing
fun.
much more obstruction. And then the second rise is due to?
Due to the passive ejection of blood in the later part of systole.
No. 80 to 90%, correct me if I'm wrong, but this is my understanding of HOCM. 80 to 90% of blood is ejected in the first phase itself.
Yes, sir.
There is very little ejection in the second rise. The second
Yes.
rise is due to reflected wave. It's a tidal wave.
Yes.
Okay, so that leads me to another question. What are the three hemodynamic phases of HOCM?
Hemodynamically, sir, the phase 1 is the asymptomatic phase, sir, in which
No,
there is a,
hemodynamic phase, not phase. Okay, go ahead.
so there are symptomatically, sir, there are 4 phases, sir. First is the pre-symptomatic or asymptomatic phase. Second is the classical HCM phase. Third is the negative remodeling phase, and fourth is the burnt out phase, sir.
That is
Those
natural
are
history.
clinical features. He's
Yes,
asking,
yes,
what sir is asking, what are the hemodynamic three phases? What is happening to the LV pressure, systemic pressure in the cardiac cycle?
Adit, you are right. You told about the pulse, then you tell about the pulse pressure. What
yes,
is
sir.
about the S4? What is the
Yes, sir.
reversal of the split? Then
Yes, sir.
click. All these are the important points to differentiate.
Yes.
The three phases of HOCM are phase of rapid ejection, phase of progressive obstruction, and the third one is leak phase. What is leaking?
Leak. So the leak is due to the MR mitral leak.
Excellent. It is a late
Yes.
systolic leak,
Yes.
mid to late systolic leak due to MR. Excellent.
MR.
So this
So
was
those are
described.
correct. Sorry. Go ahead, Dr. Dhiraj.
So this was described by Wiggle in, I
Yeah,
think,
Wiggle.
Rabbits. He had plotted the aortic pressure versus the LV pressure. Okay, and
Yes.
from all our understanding are because of Brownwald and Wiggle in separate work that they have done on animals. So that is why it is important to understand these phases. And the phase of leak does not exist in non-obstructive HOCM.
Yes, sir.
Okay, so this is
Yes,
very
sir.
important. Yes, so that's why when you draw, Wigger's diagram, you will actually have to draw a prominent, V wave also. At the, people always draw the LA pressure, the aortic pressure and LV pressure, but nobody
Yes, sir.
draws a parallel changes in LA also. So
Yes,
this
sir.
is something that you need to know. What is Venturi effect?
Venturi effect, sir, is due to the elongated anterior mitral leaflet. When it occurs in systole, sir, due to the LV contraction, the anterior mitral leaflet is pushed more closer to the septal wall.
And why is it pushed? That's the whole question. Here you would need to go back to your
Because
12th
of the,
standard
sir,
physics.
drag effects,
So
there is
what is
one drag
drag?
phenomenon because due to the decrease in the LV volume, sir, and increased intraventricular septum and LV hypertrophy, sir.
No. So remember this. In fluid dynamics, energy remains constant. This was the theorem by Bernoulli. So pressure head plus gravitational head plus kinetic head is constant. Now,
Yes, sir.
gravitational head, we have literally everything is same. LEOT
Yes.
is about half a centimeter above
Is
LV, so that is
neglected.
not important.
Yes, sir.
But as the blood gets ejected through a narrower LVOT, the velocity increases.
Increases.
Whenever
Yes.
velocity increases, if gravitation is constant, what should drop? Pressure should drop.
Pressure
And
should
that
drop.
pressure will create a suction. Right, in negative pressure. It's like when a local train arrives into a platform at a very high speed, you are asked not to stand right at the edge of the platform. You get pulled in.
Low
So
pressure
this is
circuit.
very
Yes.
important to understand Venturi effect. So
Yes.
Venturi, Bernoulli, Laplace, Hagen-Poiseuille law. 4 important physics related, what do you call, principles that are applied in cardiology.
Yes,
Can you
sir.
tell me where else is Venturi effect demonstrated in our branch?
And then I do cardiology, remember.
आज मॉर्निंग में भी तो डिस्कस हो रहा था दो तीन जगह तो
सर
होगा ना, वेंचुरी कहाँ कहाँ पे हो?
सुप्रावल्वुलर रेस में सर कोंडा इफेक्ट में सर वेंचुरी। सुप्रावल्वुलर रेस।
No, one of the two of the what do you call fates of VSD? We have 7 or 8 fates of VSD, right? Two of the fates are related to Venturi effect. Which are those? Now I've given you a hint.
अरे VSD का क्या हिंट देने की कोशिश कर रहे हैं?
5 से 9 साल के बीच में क्या
Yes.
होता है VSD वालों को?
Fate of
Adit,
USD Ison.
Adit, this
AR
Venturi effect you can have, you know,
AR
ASD,
अगर
VSD,
AR perhaps.
yes
AS, valvular AS, and
Yes,
can
sir.
it be in peripheral per PS?
yes sir. गजूल phenomenon में सर in VSD if it is associated with the
Actually,
AR or
you must talk about VSD with AR. That is the first important thing. Second is associated sinus of Valsalva aneurysms. Most of the time in VSD AR, you will get an additional sinus of Valsalva aneurysms there because of Venturi effect. So
yes sir.
Venturi effect is always there with a high pressure and a low pressure. When they are together, then you will get a Venturi effect.
Yes sir.
Okay, move ahead.
Yes.
Now coming to echocardiography.
I think the time is catching up.
Yes.
You also get Venturi in pursely breathing of COPD.
Yes.
That's again the mechanism: intrathoracic pressure, pleural pressure falling. Breathe slowly so that the alveoli don't collapse and you empty more. And you also get Venturi in winking coronary sign. Again published, and that's the mechanism. The
It is not a
turbulent
winking,
sudden flow
it
leads
is
to the
not a
coronary
winking
killing of
coronary
VSR.
sign. It is Dr. Kamal Sharma's sign in
Yes, sir.
patients with the VSR.
Yeah,
So
it
that
should
is
have been
another mechanism of
eponymous.
VSR. Again, Venturi effect there also comes into play.
What the echo shows?
Parasternal long axis view showing non-dilated LV with LV dimension of in diastole 40 mm and in systole 20 mm with ventricular septal thickness is 22 mm and posterior wall thickness is 15 mm with parasternal short axis view showing normal systolic LV function. Now apical 4-chamber view showing
Which is the single most important view in a patient of HCM to diagnose or rule it out?
apical 4-chamber view.
No,
Because
this is very important.
Why? Why 4-chamber?
Left ventricle.
You can say
LVOT
5-chamber also, but yeah, what? Yeah.
Asymmetrical septal hypertrophy and
वो तो
LV
यहाँ
outflow tract.
तो दिख जाएगा ना, प्लेक्स में दिख जाता है. On the contrary, you can do
LV
M mode and
outflow
measure.
tract obstruction.
वो भी दिख जाता है प्लेक्स में.
I'm hinting about a variant of HCM that is commonly missed.
Apical.
Absolutely. Apical HCM. Apical HCM is something that you'll not pick in other views, right? You'll need to show that unless you're taking a short axis apical, then in which case you'll not be able to see the basal variants. So 5-chamber view, that's the most important view. So gradient ka story kya ultimately, where are we? Gradient is a predictor, not a predictor. Her MCQ, her exam, her entrance, her viva, same question. Is it a predictor of outcome or not a predictor of outcome?
Not predictable, sir.
Pakka.
It is a predictor of progression of heart
predictor.
failure, but not a predictor of syncope.
No, but sudden cardiac death
Sudden
also
cardiac
includes
death,
LVOT
sir.
more than 30 millimeter of
Yes,
mercury.
yes.
It's a
It is a
weak
high
predictor, but
high,
it is a predictor.
high
It's
risk
not
feature, but
an
not a strong
Anshuman?
predictor.
yes.
Yes, sir.
It's a
Anshuman?
weak predictor.
Predictor, is
Yes,
it
sir,
30
yes,
at rest or is it 30 of dynamic?
30 rest and dynamic more than 50.
Very good. 30 at rest,
Very
50
good.
dynamic.
And
what
Anshuman,
are
Yes, sir.
the
can
variables
you
in
tell
HCM
about the
score?
sudden cardiac death here in HOCM? Why?
Sir, this is the unexpected natural death from cardiac causes heralded by abrupt onset loss of consciousness because within 1 hour of onset of acute changes in cardiovascular system.
Yes, correct. Yes, yes.
Or when you have not observed a patient, when the patient had been seen live and well 24 hours before, within 24
Yes.
hours.
Within 24.
Within 24.
Okay,
How
go
do you
ahead.
calculate septal thickness? In which view should you comment about septal thickness? Basal, mid, and apical?
Sir, in M mode,
Septal thickness always is in short axis. That is as per the guidelines.
okay.
Which is the best imaging modality to assess the septal thickness?
Cardiac MRI, sir.
Very good. Why is it important? What else it does tell you? Is cardiac thickness a predictor of sudden death?
Yes,
Late
sir.
gadolinium analysis.
And what else it will pick up?
Late
Very
gadolinium
important.
enhancement.
Right. How much? How much is a
More than
predictor of a?
more than 15% of LV mass, sir.
तो दो जगह अलग अलग लिखे हैं ब्रोनवॉल्ड के दो चैप्टर्स में. If you go through the MRI chapter, it's 10%. If you go through HCM chapter, it's 15%.
15%.
But दोनों ही राइट हैं, दोनों ये दो सेपरेट स्टडीज हैं. एक की प्रिडिक्टिव वैल्यू अलग है, दूसरे की प्रिडिक्टिव वैल्यू और ज्यादा है. सो एक में सेंसिटिविटी, एक में स्पेसिफिसिटी है. So 10% gives you a sensitivity. Specificity comes with 15%. 15% is taken as in the guidelines as the more strong predictor. And if it's more than 15, you do. LG का pattern in HCM कैसा होता है?
Epicardial.
Epicardial. Transmural या सब endocardial नहीं होता?
Amyloidosis is subendocardial.
Asymmetric patchy होता है ना? That's how you pick up.
One more thing that MRI picks up and which is often missed in 2D echo, that is apical aneurysms. And
Correct.
recently, apical aneurysms have been an important predictor of not only strokes because of clots being formed, but also sudden cardiac death because this aneurysmal tissue is after all scar. So that I think you can often miss in HOCM.
Yes.
Mechanism of MR क्या होता है वेंचुरी के अलावा इसमें?
Drag.
Sir, one is second is drag effect, and third one is if automitral angle is less than 120 degree.
No, sir is asking
And
about inherent mitral abnormalities
MR.
that are associated with
Yeah.
HOCM. So, like there are
yes,
the direct insertion of AML into the papillary muscle. So that is why MRI is again needed when there is an
yes, sir.
intrinsic mitral valvular abnormality. So you have to talk
Because
about that. There are
you then
four of them.
decide about the surgery, right? Because
Yes.
Yes,
if
sir.
you then the MR will
Anshuman.
not rectify. It will not correct unless
Anshuman.
so a lot of patients have accessory papillary muscle, etc.
Anshuman.
Yes, sir.
So finally, what is your diagnosis after echo?
Sir, my diagnosis is hypertrophic obstructive cardiomyopathy with mild MR in sinus rhythm, normal LV systolic function with family history of sudden cardiac death, currently in NYHA class 3.
So if it is your diagnosis, how will you treat? What is the drug treatment of HOCM?
Sir, among drug treatments, sir, first line treatment is either beta blocker or calcium channel blocker in dihydropyridine group. Like
Patient बोलता है सर आप बोलो वो ले
What is
लूंगा
the
दोनों में से क्या दोगे?
The new thing is
What
coming
is-
now. It is available.
what
in
is the
India.
new drug, Anshuman, you will give?
Because sir is CSI president,
Sir-
and that new drug is
Sir-
going to be there in CSI.
Yes, sir. Now coming to cardiac
Yes, sir.
myosin inhibitor, among which two drugs, one is currently mavacamten and second is
कोई
aficamten.
ट्रायल पता है मैवा कैप्टन का कोई ट्रायल?
Yes, sir. Most common famous trial two one is more like Explorer SCM and second one is Velar SCM trial.
क्या साइड इफेक्ट
Last-
ध्यान रखोगे ये पेशेंट्स को अगर तुमने मावाकेम्टन चालू किया?
Yes, sir. It leads to decrease LV function, EF, ejection fraction, and second one is to look for the cytochrome inducer. Like it's in metabolized by cytochrome 2C19, 2C9, and 3A4. So along with
what
avoid
percentage of
the-
patients ये LV dysfunction अगर होता है तो what percentage and is it reversible or irreversible?
this is the reversible, sir.
Or what percentage get it?
10 to 15.
इतना ज्यादा? एक्चुअली तुम राइट भी हो कौन सा सबसेट में 10 to 15% था The whole controversy is around that Asian subgroup and especially Indians. They are
Yes.
arguing that to get more LV dysfunction.
that is
Debatable.
debatable.
Correct.
So how you follow such patients? You know, a young patient, 30 years, you have to tell him what you have to do, what you have not to do as a physician, cardiologist.
Sir, as per management protocol, two things is more important. One is prevention, secondary, primary or secondary prevention, and second one is symptomatic treatment. If we are going to prevention part, then in this case, two major marker is present. First one is the history of family history of sudden cardiac death, and second one is unexplained syncope. So we plan for as per ACC AHA 2024 guidelines, if among more than one or more than one major risk marker is present, then consider for ICD implantation. So in these total five markers, if more than one, then consider for more class 2A indication for ICD implantation, sir. And
So
second
before
part
ICD, is there any other drug that you would use? You have
Yes,
given
sir.
beta
We are
blocker. You
going
have
to
also given mavacamtan. अभी और कुछ दे सकते हैं?
yes,
Patient
sir.
बोल रहा है मुझे अभी भी dyspnea हो रहा है.
Diisoparamide, very cheaper drug. So we
So you want to
choose, but
combine disopyramide with mavacamtan?
no, sir, with beta blocker, sir.
हाँ.
Yes,
तो
sir.
फिर मैंने बोल दिया ना, patient is on beta blocker and mavacamtan. Patient is dyspneic. What more can you give? There is a editorial.
Low dose diuretics. Low dose diuretics, sir. If you see.
No, don't give
Never.
diuretics. Why not?
Never.
Why not? अभी तो किया preload घटाना नहीं है, LV
Yes,
छोटी
sir.
करनी है, तो क्या दोगे? SGLT2 inhibitor. Go through and search
Yes.
papers. That's the next thing in HCM. And even when you look at the Explorer HCM or you look at Valor HCM, there are a lot of big patient subgroups that were on SGLT2. And SGLT2 is touted as another. So it's already class 2A. Anyway, it's a therapy class. If you were to look at HFpEF, it's class 1.
Yes, sir.
Yes.
Right? And in HFpEF trials, there were subgroup of patients which included not only amyloidosis but also included HCM, burnout HCM,
But
or
there
even
are very,
non-burnout.
very small group of patients.
Yes, sir.
No.
HCMK, there are
So,
even 3 papers now that have been published in
but they are
25.
yeah, very small
Yeah, very
subset
small
of
subgroup.
patients.
Correct.
But I think we have catching up the time, and if some special comments from Dr. Kapoor sir. Kapoor sir.
नहीं, I think let the examiner tell how they have done, and I think it's been a wonderful class. बहुत ही अच्छे teaching points and
Yes, yes.
exhaustive session.
Fully
I
agree what you are saying.
लोग सुन रहे हैं, they would have benefited a lot. Excellent, excellent. कैसा सर इनका performance अब आप
नहीं,
लोग?
अच्छा था sir. They are very well read with the trials. They know the therapies. They know the approach. I think the whole idea of the class was to ask them questions that are tough, that they've not heard of, and that's why I was deliberately asking questions that are otherwise, credit questions only. So they really done well. They're well prepared for dynamic auscultation. I think I covered a lot of theory in the first part, and they have demonstrated that in practical case as well. So well done, well done.
Excellent, excellent. Lot of learning.
Lot of learning, yes. Great.
Thank you.
Thank you, Dr. Mahajan, Dr. Sharma,
Thank
Thank
you
you,
so
sir.
much.
Thank you. Good night.
Thank you to the
enlightening us by
Sir,
discussion. I think
Always a
it's
pleasure.
for,
Always a
yeah.
for
pleasure.
residents, it's a lesson how to work further on, move on to understand the basics.
Right. So thank you very much for having me. Always a pleasure.
So, sir, with
Thank you,
the
Dr. Mahajan, sir.
sir, with the permission of the panel member, I would just like to extend a formal vote of thanks to everyone. So just allow me for a few minutes. Sir, I would just like to inform that today's session had been attended by 285 students across the India. Those who have got benefited from today's session, which was very lively session, I must say. So once again, good
Sunny,
evening
next time से 500 से नीचे नहीं होना चाहिए.
definitely, sir, we will ensure that. So once again, good evening to all the respected doctors. And on behalf of Ajanta Pharma, I, Gaurav Dave, DGM Marketing, would like to take this opportunity to put the formal vote of thanks on record for making today's third DMPG Ajanta Cardio Master workshop a grand success. So thanks to all the esteemed panel members and participant PGs. We would like to thank our today's PG speaker, Dr. Anshuman, as well as Dr. Aditya for insightful presentation. And also we would like to extend our special thanks for our expert speaker, Professor Dr. Kamal Sharma, for the insightful presentation. And very, very special thanks to our course director, Dr. Ajay Mahajan sir, and Dr. Dhiraj Kumar sir for all the guidance. We would like to once again acknowledge the contribution of today's expert panelist, Dr. Aditya Kapoor sir and Dr. S. Tiwari sir, as well as also Dr. Kamal Sharma sir. So thank you all participating DM as well as DNB PG students for investing the time in learning from the stalwart of the cardiology. And we encourage all the participants for the active participation in all the future workshop too. So please do not forget to log in once again on our fourth workshop, which is planned on the date 7th November and on the same time. That is, it will start at 8:30 p.m. So once again, doctors, just to reiterate, that quiz will be live now at the end of the session and will remain live till tomorrow 12 p.m. So with this, we conclude our today's third session on the DMPG Ajanta Cardio Master Workshop. Thanks to one and all. Good night and have a happy weekend ahead. Thank you.
Good night.
Thank you, sir. Tech team, I think now we can go offline. Tech team.
Yes, sir. Just
Thank you, Tiwari sir. Thank you, Sharma
Thank you,
sir.
sir.
Thank you. Thank you.
Thank you, sir.
Thank you, Mahajan sir.
Thank you. Good night, everyone. Thank you.
Thank you.